Remember, tissue injury immediately sets off alarm bells, releasing DAMPs and inflammatory cytokines. This sparks SIRS, or systemic inflammatory response syndrome, which then triggers a massive neuroendocrine stress response. We're talking the HPA axis flooding the body with cortisol, catecholamines, and glucagon. This whole cascade literally throws the patient into a profound state of hypermetabolism and insulin resistance. Here's our roadmap for today's clinical deep dive. We'll be hitting up resource reprioritization, muscle autocannibalism, the hepatic acute phase response, starvation versus injury, ERAS protocols, and finally, the complete pathway.
Okay, Section 1, resource reprioritization. After a major injury, the body enters this completely ruthless state of triage just to keep the patient alive.
In a crisis, all available energy and nutrients are forcefully redirected to the organs that are absolutely essential for survival. Think of these as the nutrient receivers: your liver, the immune system, healing wounds, and vital organs. But, that massive energy has to come from somewhere, right? So resources are basically stripped away from peripheral tissues. This turns skeletal muscle, adipose tissue, and skin into involuntary nutrient donors. Now, this metabolic shift is great for supporting inflammation and tissue repair, but man, it comes at the steep cost of progressive, severe muscle loss. Which brings us to Section 2, skeletal muscle autocannibalism. Let's zoom straight into the cellular level and see exactly what this autocannibalism looks like. Now, here is a massive, high-yield exam pearl for you, the ubiquitin proteasome pathway. This is the primary engine that's literally ripping apart muscle protein to release amino acids during critical illness. Normally, you renew maybe 1 to 2% of your muscle protein every day, but add in the heavy influence of cortisol, catecholamines, and inflammatory cytokines, protein breakdown massively outpaces synthesis. Damaged or unwanted proteins get chemically tagged with these little ubiquitin molecules, and then they're delivered to proteasomes. Think of proteasomes as cellular wood chippers, using ATP to dismantle those proteins right down to raw amino acids. 500 grams. That's a staggering number. That is the equivalent amount of skeletal muscle a patient can lose every single day in severe sepsis. We can actually measure this cellular breakdown indirectly through urinary nitrogen loss, which can hit 14 to 20 grams a day. Colossal losses like this perfectly explain that rapid, visible physical deterioration we see in critically ill patients in the ICU. Actually, if total body protein loss hits around 30 to 40%, survival becomes highly unlikely.
This catastrophic muscle breakdown basically paralyzes multiple organ systems, pushing the patient straight toward chronic critical illness. You've got weakened respiratory muscles, leading to hypoventilation, atelectasis, and extreme difficulty weaning off ventilators. You lose gastrointestinal muscle, which reduces gut motility and delays feeding. We also see delayed wound healing, severe immunosuppression, and critical illness myopathy, where even the intact muscle fibers just fail to contract effectively. Though interestingly enough, cardiac muscle remains surprisingly protected from this wasting compared to regular skeletal muscle.
Moving right along to Section 3, the hepatic acute phase response. Let's trace those released amino acids directly from the muscle tissue right into the hepatic circulation.
Even though the liver only weighs about 1.5 kilograms, it is the absolute command center for the metabolic response to injury. Under the powerful influence of the inflammatory cytokine interleukin-6, or IL-6, the liver violently reprograms its own production priorities. It literally takes those scavenged amino acids from the skeletal muscle and uses them to rapidly pump out proteins needed for host defense, immune regulation, wound healing, and coagulation. There is an incredibly important distinction here for your exams. The liver acts as a positive acute phase reactant, meaning it rapidly ramps up defense proteins. We're talking C-reactive protein, fibrinogen, complement proteins, and serum amyloid A. But simultaneously, it acts as a negative reactant, totally dropping the production of albumin and transferrin. And here's a key physiological pearl for you. A drop in plasma albumin during major injury doesn't just mean poor nutrition. Systemic inflammation actually increases capillary permeability. This allows albumin to physically leak out of the circulation and right into the surrounding tissues. So, zooming out to whole body composition, you might actually see a patient's weight increase due to tissue edema. This completely masks the devastating loss of lean muscle happening underneath. Take a standard 70-kilogram adult male. They have about 57 kilos of lean body mass. During severe injury, that protein store plummets. But because of that capillary leak we just talked about, extracellular fluid wildly expands. You really have to look past the scale to recognize the true metabolic state of the patient.
Section 4,
starvation versus injury. Now, at this point, you might be thinking, isn't this muscle loss exactly what happens when you just stop eating?
Absolutely not. And this is a really foundational concept. In simple, uncomplicated starvation, the human body safely adapts. It shifts to burning fat and producing ketones, specifically to protect its vital protein stores. But severe injury and sepsis, they completely block those protective adaptations. Instead, the body triggers this uncontrollable auto-cannibalism. And here's the kicker: you cannot simply feed your way out of this. Aggressive artificial nutrition can maybe reduce the losses, but it absolutely cannot fully stop the muscle breakdown as long as that severe inflammatory stress response is still active. In the past, certain clinical practices actually made this catabolic cascade worse. We now know of several completely avoidable factors that worsen the injury response. For instance, even mild hypothermia spikes cortisol and catecholamines. Pumping patients full of excessive saline-rich fluids, that just promotes massive tissue edema, delayed gastric emptying, and pulmonary dysfunction. On top of that, prolonged preoperative fasting worsens insulin resistance, and physical immobility dramatically accelerates muscle wasting. Which perfectly transitions us to Section 5, Enhanced Recovery After Surgery, or ERAS. This is where we move from cellular pathology to the modern clinical solution. RAS intercepts this stress response through this beautifully coordinated pathway. Instead of just letting the inflammatory cascade run wild, we actively suppress it. We use minimally invasive laparoscopic surgery to cause way less tissue trauma. We deploy multimodal analgesia because, remember, uncontrolled pain directly stimulates cortisol release. We eliminate prolonged starvation through preoperative carbohydrate loading, which slashes postoperative insulin resistance. And we prioritize early enteral feeding, goal-directed fluid therapy, and getting patients out of bed and moving immediately to preserve that precious muscle mass. By restoring normal physiology quickly through these combined ERAS principles, hospitals can reduce a patient's stay by up to 50%. That is just a staggering clinical victory. It accelerates recovery, slashes complication rates, lowers healthcare costs, and dramatically improves patient satisfaction. ERAS is, without a doubt, one of the most important advances in modern surgery. Finally, Section 6, the complete metabolic pathway. Let's move to our grand finale and see how this all builds into one comprehensive roadmap. This perfectly maps the entire explainer for us. It all starts with the initial injury, triggering inflammation and SIRS. That activates the neuroendocrine stress response, which forces the body into hypermetabolism and severe protein catabolism, firing up that ubiquitin proteasome pathway. Those scavenged amino acids then travel straight to the liver to fuel the hepatic acute phase response, pumping out CRP and fibrinogen while dropping albumin. Ultimately, it leads to severe muscle wasting. That is, unless we interrupt it with ERS interventions to actively reduce that surgical stress and drive a much faster recovery. So, I'll leave you with this final thought. If aggressive feeding alone cannot reverse metabolic autocannibalism, what must you clinically eliminate to finally stop the cycle of muscle wasting? Well, since nutrition alone can't force anabolism during an uncontrolled illness, to truly stop the autocannibalism, you have to hunt down and clinically eliminate the underlying driver of the inflammation itself. Whether that means treating the sepsis, optimizing surgical source control, or correcting physiological instability, you literally have to shut off the fire alarm before you can rebuild the house. Thanks so much for joining me on this deep dive into the metabolic response to injury. Stay curious, and I'll catch you in the next explainer.